Welcome everybody to this session titled, Why Are So Many People Still Dying of AIDS? Turning the Tide on HIV. My name is Irene Mukui. I am the HIV and Access Medical and Affairs Leader with Drugs for Neglected Diseases Initiative. And I will be co-chairing this session with Nathan Ford, who is a scientific officer with the Department of HIV/AIDS and Global Hepatitis Program with the World Health Organization. This session is co-hosted by DNDi and WHO and St. George's University London and supported through the EDCTP5FC consortium, which includes a number of partners from several African countries. Before I hand over to my co-chair, I just wanted to make a few remarks regarding this session. And I guess the question on everybody's mind is, why are so many people still dying of AIDS despite access to antiretroviral therapy and HIV diagnosis? Just to remind us briefly, in 2020, we had close to 750,000 people who died of AIDS-related deaths. And in recent years, the number of deaths have actually plateaued at about acceptably high rates. Going back to 3 to 4 decades ago, what we saw were pictures of people who were wasting away, and having HIV was synonymous with death. And there was a lot of activism that led to great response that we see today. In the advances that have followed with affordable diagnostics and treatments and early access to treatment and test restart, we've seen this changing. And I think alongside with it, some false assumptions that we perhaps have made that people will no longer be dying of AIDS. However, despite all this access to these fantastic tools that we have a third of people living with HIV presenting or representing to care with advanced HIV disease, and at a point where they are so vulnerable to opportunistic infections and at high risk of death. So I would like to say that as we celebrate our successes, we must acknowledge that part of what we are seeing is actually a collective failure of implementation. And we do need to discuss this and go back to this conversation. So for this session, we want to revisit this agenda of advanced HIV disease and refocus, take stock of where we are, but most importantly, discuss what needs to be done. And at this point, I'd like to invite my co-chair, Nathan, to take us to the next part of the session and look forward to an interesting discussion. Thank you. Nathan, over to you.
Thank you very much, Irene. And thanks to everyone for joining this session. So we have a series of presentations in this session. We start with a number of presentations from doctors working in Southern Africa on advanced HIV disease. They've each contributed a number of important research studies in this area. We then have a Q&A session with these presenters, followed by a second session, which is a roundtable discussion with representatives from civil society, implementing agencies, and WHO. Now, throughout this session, you'll see a Q&A feature on the right-hand side of your screen. Please post your questions there, and we will come to them when we have time. So firstly, I'd like to present the moderators for this session. Angela Lois, who is an infectious disease physician, a researcher at St. George's University and Hospital in London, and leader of the Cryptococcal Meningitis Advocacy Group. And with her is Amanda Banda, who is a global health advocate in East and Southern Africa, specialized in global health politics, policy, financing, and governance, and is a co-chair of the Health Workers for All Coalition. And with that, I will hand over to our first presenter, Dr. Ajay Rangaraj, who is a colleague of mine, the lead of advanced HIV disease in the Department of HIV, Global Hepatitis and STIs at WHO in Geneva. Over to you, Ajay.
Thanks very much. Hi, my name is Ajay. I'll be talking about the current progress and future challenges that we face with advanced HIV disease. Next slide, please. So as you know, AIDS-related mortality remains a significant challenge globally. And of course, we have the UN AIDS targets of 90-90-90 or 95-95-95 that really is attempting to bridge this gap. However, advanced HIV disease, of course, presents problems in reaching the second and third 90. And as you know, between 2010 and 2019, we've seen a 54% decline in mortality in women, 43% decline among men and boys. And however, this discrepancy represents an important gap in knowledge And we also know that over time, AIDS-related deaths have reduced. However, we still have some substantial ways to go. And as Irene earlier said, we have nearly 700,000 deaths occurring in 2019, and East and Southern Africa being the worst affected. And according to estimates, nearly 50% of men and 30% of women start ART with a CD4 of less than 200 cells. Now, this is quite important because, again, this represents a discrepancy and also suggests that these men and women are at greater risk even when they're starting ART. Next slide, please. So why is advanced HIV disease a problem? So, there's early mortality, there's a high incidence of co-infections, we have more men suffering from advanced HIV disease, we have increased adverse reactions such as paradoxical TB-itis, and of course, increased costs of care to the individual as well as to healthcare programs as well as a consequence. Next slide, please. So why is it important? So as I earlier said, we see early mortality, and this is primarily due to very poor immune status and, of course, very high risk of developing co-infections such as tuberculosis, cryptococcus, and severe bacterial infections. We have some further insights from the reality trial published in 2018 to show that even with ART, death from TB, cryptococcal meningitis, and severe bacterial infections were high. Now, co-treatment of those with co-infections and ART, if not carefully provided, therefore the timing of intervention becomes critical, can result in life-threatening paradoxical immune reconstitution. And then, of course, it's also important to acknowledge that those with advanced disease are not simply patients who present to care late. They're also those who might be reinitiating care as well. Next slide. So this is just a summary of the causes of hospitalization among people who have advanced HIV disease. And you can see that the top causes are, of course, AIDS-related in adults, and then tuberculosis being one of the leading causes with cryptococcal meningitis, and then, of course, bacterial infections sort of emerging as the key causes of hospitalization. Next slide, please. So what is the WHO response? So WHO has produced several guidelines in the past few years, which includes a guideline on advanced HIV disease, rapid ART initiation, and then the management of cryptococcal meningitis and cryptococcal disease, and then also histoplasmosis. And of course, we have the main consolidated guidelines that provides guidance on what to start and when to start ART with. So now this, of course, has now been incorporated into a single chapter, which we launched recently just a couple of days ago for the consolidated guidelines. So we have a new integrated chapter that brings together all of this guidance in a single chapter. So it is much more approachable to policymakers and program managers when planning their programs. Next slide, please. So I've just presented sort of the two key headliner recommendations because there are, of course, a number of recommendations that deal with the management of cryptococcal meningitis, histoplasmosis, so on and so forth. So again, we reiterate that rapid ART initiation should be offered to all people living with HIV following a confirmed HIV diagnosis and clinical assessment. A package of interventions that include screening, treatment, and/or prophylaxis for major opportunistic infections, rapid ART initiation, and intensified adherence support interventions should be offered to everyone presenting with advanced HIV disease. Next slide, please. So to sort of break this down to make it easier to understand, we have several steps that are involved here. So when we say diagnosis or diagnostic interventions, it means that you would perform systematic screening for TB and use a molecular-based WHO recommended molecular rapid diagnostic test. You may use an LF lamb, a urine LF lamb, to assist with diagnosis in those who have very low CD4 counts. This is, of course, applicable broadly to advanced HIV disease. And of course, screening for cryptococcal antigen, screening with a cryptococcal antigen test for cryptococcal meningitis. Now, and the next stage is, of course, prophylaxis. And this includes the use of cotrimoxazole to prevent PCP pneumonia, TB preventive treatment, fluconazole preemptive therapy, or fluconazole prophylaxis based on the results of your cryptococcal antigen screening. And then, of course, ART initiation as soon as possible. This is, of course, a separate consideration if the individual has signs and symptoms of TB or cryptococcal meningitis. And then, of course, adapted adherence support. So this would imply that you would need to do some tailored counseling for adherence. Next slide, please. So really the question is now, you have a sense of where we are, but I think the next steps are sort of very important to think about, because we continue to have a strong focus on achieving the UNAIDS targets of ending AIDS by 2030. We also are very focused on ensuring the AHT package of care is prioritized as part of essential health services during the COVID-19 crisis. And then, of course, a question that we have is, what are additional tools that we need to ensure management of critical co-infections that can help us reach these targets and reduce mortality? We have an upcoming consultation on severe bacterial infections, because this again has remained a sort of large research question in the area of advanced HIV disease in recent times. So I'm happy to say that we are planning a consultation for later this year. We're currently examining the role of regional adaptations of advanced HIV disease to account for locally endemic opportunistic infections. And this could, of course, include diseases such as thalaromycosis and emergomycosis in different geographic regions. And of course, there is a precedent in that we have a guideline for histoplasmosis, which does have a regional predilection. And we also will continue to support several implementation projects that are currently ongoing. This includes the Clinton Health Access UNITAID project for improving access to liposomal amphotericin. Next slide, please. Again, we're focused on building back better. I think COVID has had a tremendous impact on HIV services, although they have now slowly recovered. But again, it's important to acknowledge that we bridge this crisis and ensure that everyone receives all the interventions they need. Also support the generation of national and subnational estimates to help us understand better the regional and local context of AHT in countries. Also, again, we need to find better ways to account for local implementation challenges, improved models of care for individuals with advanced HIV disease. And of course, I think another important exercise is we are currently supporting work on modeling for advanced HIV disease to identify cost-effective approaches to help inform countries on efficient allocation of resources and also ensure the greatest population level benefit. Yeah, that's it from me. Thank you.
So I'm going to chair the next session and ask some questions. So clearly we need R&D. However, what if we have already many of the solutions? What if already many of the tests, medicines and interventions already exist that can drive down HIV-related mortality? What if actually it's a failure of implementation of existing technologies and interventions? In the last 10 years, there have been a number of mortality-reducing interventions, from ACTA, from REMSTART, STAMP, to name a few. Access to essential tests and medicines remains a huge issue that needs to be urgently addressed. However, implementation strategies, such as investment in training in local leadership and quality improvement in healthcare delivery, are implementation strategies that are rarely focused upon, and this does need to change. And this is the case whether we're talking about advanced HIV disease or AMR or pandemic preparedness. Next slide, please. I'm delighted to have three speakers today who will be putting the case for failures of implementation in tuberculosis and CNS infections being key drivers of HIV-related deaths. The first two speakers will be talking about CNS infections, and our last speaker will be focusing on TB. I just wanted to flag the TRIP project, which the results of which are going to be available imminently. TRIP is translating the intervention from the REMSTART trial into routine care. And these type of studies are essential in terms of identifying powerful implementation strategies which allow key interventions to reduce deaths in routine care. This is the work of our first speaker, Professor Miffananga. Professor Miffananga is a global health and clinical research expert. He's a director and chief research scientist for the National Institute of Medical Research in Tanzania. And Professor Miffananga will be talking about packages of tests and medicines for CNS infections to reduce HIV-related deaths. Over to you, Professor Miffananga.
Yes, okay. I'm presenting this study on driving reduced AIDS-associated meningoencephalitis, the DREAM study, on behalf of the team. Next slide, please. So the study was a multi-center using implementation science. We focused on reducing mortality from central nervous system infection and developing new model of care. At the same course, describing epidemiology and evaluating new diagnostic for CNS infection. We used before and after design, including 3-phase observation, training, and implementation, and we evaluated primary endpoint of 2-week all-cause mortality, and secondary endpoint of 10-week and 6-month all-cause mortality. We carried out this study in sites in Tanzania, Cameroon, and Malawi. Next slide, please. The developed DREAM algorithm targeted diagnosis and treatment for HIV-related CNS infection, including cryptococcal meningitis, and the quality improvement with the central core, including mapping, optimizing clinical and laboratory pathway, and increasing physician laboratory communication. We also had the education program tailored for frontline health workers. Next slide, please. During the observation phase, we enrolled the 139 participants were recruited, and 85% of these had advanced HIV disease, although majority did not receive baseline CD4 counts or viral load tests. And as you can see in this table here, over 2/3 of participants were ART experienced, and over 3/4 were critically unwell with abnormal mental status. Next slide, please. The majority of participants did not receive confirmed diagnosis. As you can see in this table, it means they were treated empirically. Over 80% had lumbar puncture ordered, but performed in 30 only. And cerebrospinal fluid specimen were analyzed in 23%, but only 10 had confirmed the diagnosis. And majority of this coming from Malawi site, the site that has long-standing research and implementation support, which might not be very representative of all the sites under the Ministry of Health in Malawi. So next slide, please. During implementation, we enrolled 356 participants. Overall, the baseline characteristics were broadly comparable between the two phases, I mean implementation and observation phase. And we observed that over 2/3 of participants were also, again, ART experienced, and 3/4 were critically unwell with abnormal mental status. The problem of missing CD4 and the viral load results were much reduced for CD4 testing during the implementation, although slightly reduced, but remained significant for viral load. So next slide, please. At the end of implementation phase, 3/4 of the participants had probable or confirmed diagnosis of CNS infection, and clinically we had improved substantially, with almost all participants having lumbar puncture unless it was contraindicated. And as you can see, over 75% of CNS cases were confirmed either microbiologically or radiologically. If you remember earlier, I said only 10% during observation phase were confirmed cases. Next. So you can see that the DREAM intervention appear to substantially reducing mortality from HIV-related CNS infection at 2 weeks. And the data compares favorably with data from recent systematic review and meta-analysis of HIV-related meningitis. Next slide, please. And therefore, we are able to conclude that significant number of deaths of people living with HIV, even presenting with critically unwell at hospital, are preventable using existing diagnostic and treatment. And again, 2-week mortality outcome comparable to clinical trial outcomes can be obtained through such a system. However, we still have challenges with CD4 and viral load, and we still have work to do to improve this. And we think that this DREAM approach needed to be scaled up to more countries. Next slide, please. So my colleague earlier talked about this, so I won't talk much about it. Next slide, please. We really acknowledge all the people that are mentioned in this slide. We could not put everybody and all the organizations that are mentioned here. Next slide, please. At last, we are very happy to announce launching of a new non-for-profit company, Light Africa, leveraging implementation for global health transformation Africa. It's an African-led initiative with Dr. David Meyer from IDI in Uganda, and has a lead and permanent secretary, Professor Sami from Malawi. And this company want to take over the implementation of DREAM, and TRIP has a training hub for the health workers and implementation vehicle for mortality and morbidity reduction intervention in Africa. With those few words, I thank everybody for listening. Thank you very much. Over, back to you, Angela.
Thank you, Prof. Mfananga. For the Q&A, which will be after the speakers, please post your Q&A on the right side of your screen. Our next speaker is Professor Nilesh Govender, who will be talking about the 5FC access program in South Africa. Nilesh Govender is a centre head at the National Institute for Communicable Diseases in Johannesburg, South Africa, and professor in the School of Pathology at Wits University. Over to you, Nilesh.
Thank you for the opportunity to present at IAS 2021. I'm going to be discussing cryptococcal meningitis in hospital outcomes in a South African 5FC access program. In the landmark ACTA trial, it was found that for HIV-associated cryptococcal meningitis, a 1-week short course regimen of amphotericin B and 5FC or Cytosine had the lowest 10-week mortality of 24% and less toxicity than the previous standard of 2 weeks of ampho B and 5FC. The 2018 World Health Organization guideline recommends this short course induction regimen as the preferred option, followed by fluconazole monotherapy in the consolidation and maintenance phases. 5FC as a key component of the first-line regimen is now included in the WHO Essential Medicines list. In contrast, South Africa still recommends an alternative induction regimen which excludes 5FC. Why is this? Firstly, 5FC is not registered by SAHPRA, the South African Health Products Regulatory Authority. The costs are still high, and there are few manufacturers of generic 5FC. However, the National Essential Medicines List Committee in South Africa conducted cost-effectiveness analysis in 2019 and recommended inclusion of 5FC on the South African EML as soon as SAHPRA registered this product and a price reduction was negotiated. To catalyze this process, a national 5FC access program was set up for cryptomeningitis in 2018. 5FC is obtained through Section 21 of the Medicines Act, which governs access to unregistered medicines in South Africa. And by 2021, as shown on this map, the program had expanded to 59 hospitals across South Africa in several phases. we leveraged on existing surveillance conducted by the NICD to monitor outcomes of adults with laboratory confirmed cryptococcal disease treated through this access program. Surveillance was conducted at 19 sites between 2018 and 2020, and data collected by nurse surveillance officers, by medical record review and interviews during patients' hospital admissions. During the study period, over 10,000 cases of laboratory confirmed cryptococcosis were diagnosed, and 20% of these cases were admitted to sites with 5FC access. Case report forms were completed for 85% of these patients, and of these, 1,539 patients received antifungal treatment and formed the main analysis cohort. Of this cohort, almost 40% were prescribed induction regimens containing 5FC, most AmphoB plus 5FC, and the remaining patients in the cohort received other regimens, mostly the standard regimen of AmphoB plus fluconazole for 2 weeks. We found variation among the 19 sites in terms of cryptococcal disease case numbers, as well as proportions of patients treated with 5FC containing regimens. In terms of the description of the cohort, the median age was in the late 30s. Most patients were male, 80% with a CD4 count less than 100, 2/3 with high viral loads, and 1/3 on concurrent TB treatment. Just over a quarter had altered mental status at diagnosis, and 3/4 raised intracranial pressure. And we found some differences between those treated with 5FC and other regimens. I'll show you this on a later slide. In terms of treatment and outcomes, we found that the crude in-hospital case fatality ratio was lower among those treated with 5FC, 24% versus 37% treated with other regimens. And those treated with 5FC also had shorter hospital admissions, a median of 10 days versus 14 days for other regimens. On multivariable analysis, those aged 30 to 49 years old were more likely to receive 5FC than the youngest reference age group, and ART experienced patients were also more likely to receive 5FC containing regimens. This was our main analysis after adjusting for age, sex, CD4 count, viral load, TB treatment, as well as altered mental status and hospital site. Patients treated with a 5FC containing regimen had a 42% reduced in hospital mortality than those treated with any other regimen. This slide shows the Kaplan-Meier curves. The curves diverge fairly early on within the first week of treatment. So in conclusion, the in-hospital mortality of 24% for patients treated with 5FC in this group of severely immunosuppressed patients was similar to the 10-week mortality reported from the ACTA trial. 5FC containing regimens were associated with a 42% reduced adjusted odds of mortality, and we found that 5FC could be feasibly added to routine treatment for cryptomeningitis in a resource-limited country. Urgent action is needed to ensure that widespread access to this life-saving, yet still unregistered medicine is maintained. I'd like to acknowledge Rudzani Mushao, an epidemiologist at NICD who led the analyses, as well as various groups and members of the Advanced HIV Disease Technical Task Team. And finally, I'd like to acknowledge the Germ Surveillance Network. Thank you very much.
Thanks very much, Nilesh. So powerful implementation strategies, and the latest with one key medicine, Cytosine, affording massive reductions in inpatient mortality. Our next speaker will be giving us a whistle-top tour of mortality-reducing interventions for prevention, diagnosis, and treatment of tuberculosis. Professor Graham Menkes is an infectious diseases physician, the second chair and deputy head of the Department of Medicine at UCT. Please keep your questions coming in the Q&A. Thank you. Over to you, Professor Menkes.
Thanks very much, Angela, and thanks for the opportunity to address the audience today. I will briefly review TB in the context of advanced HIV, evidence regarding major interventions for reducing HIV-TB mortality, and gaps in their implementation in high-burden settings. HIV is associated with a heightened risk of TB at all CD4 counts, but the risk is amplified as the CD4 count declines in individuals who do not initiate ART and goes down in patients started on ART, as the graphs show. At low CD4 counts, patients are at particularly high risk of more life-threatening forms of TB. Post-mortem studies have shown that around 40% of HIV-positive patients dying in low and middle-income countries have TB, and about half of these, the TB was undiagnosed before death. HIV-TB is estimated to cause approximately 200,000 deaths worldwide annually. Broadly, approaches to reducing HIV-TB deaths include ART, TB preventive therapy, TB screening, and improvements in diagnostics and treatment. In terms of TB preventive therapy, or TPT for short, three main approaches are considered in high burden settings. INH preventive therapy, or IPT, for 6 to 36 months. And IPT is currently the most widely used approach. The combination of INH and rifapentine taken weekly for 12 weeks, referred to as 3HP, and the combination of INH and rifapentine taken daily for 1 month, referred to as 1HP. For IPT, 2 trials conducted in the ART era, one in South Africa, the other in Cote d'Ivoire, have demonstrated that 12 or 6 months of IPT, respectively, provide benefit when added to ART, reducing the incidence of TB by 37% and 56%, respectively. In the Temprano trial, on the right, conducted in Cote d'Ivoire, follow-up over 5 years showed that IPT was associated with improved survival. Rifapentine is a potent rifamycin with a longer half-life than rifampicin. Combined with INH, it has been shown to provide a shorter course alternative for TPT. In the Prevent TB trial, 3HP was non-inferior to 9 months of IPT, including in the HIV-positive subgroup. In the Brief TB trial, that only enrolled people living with HIV, 1HP was non-inferior to 9 months IPT. In both these trials of the shorter course INH rifapentine combinations, treatment completion was higher and adverse events were fewer with the short course regimens, which are now included as options in WHO guidance. There are currently major challenges, however, with respect to rifapentine accessibility. The limited number of suppliers, limited registration outside the US, its cost, and the current formulation resulting in a large pill burden for 3HP and 1HP are all being addressed. The WHO recently issued an invitation for expressions of interest from manufacturers for product evaluation of new formulations. Addressing these issues, it is hoped, will allow increased availability of 3HP and 1HP to facilitate broader TPT coverage globally. In terms of TPT coverage, important gains have occurred globally in the last 3 years, with the world on course to meet the 2018 UN high-level meeting on TB commitment for 6 million people living with HIV having received TPT by 2022. However, these global figures hide the wide variation between countries, with only 5 countries responsible for 2/3 of this TPT provision. The map illustrates the wide variation in TPT provision to HIV-positive patients starting ART in high-burden countries in 2019. In most of these countries, coverage was less than 75%, and some of these countries less than 25%, the average being 50%. Clearly, there is potential for wider and more equitable coverage of TPT that would in turn contribute to fewer HIV-TB deaths. In terms of TB diagnostics, the 2 most important breakthroughs in the last decade have been the cartridge-based PCR assay, the Expert, which has been followed by the next generation Expert Ultra, which can be conducted on sputum and extrapulmonary samples. The sensitivity for sputum Expert Ultra is up to 90%. That's provided a sputum sample can be obtained. And this sensitivity is about twofold higher than the sensitivity of the sputum smear. And the urine liporabdomannan lateral flow assay, or LAM-LFA, has a sensitivity around 50% in patients admitted with HIV. While this appears a poor sensitivity, the value of this assay is that it can be conducted in 30 minutes at the point of care and performs best in patients with the highest mortality risk due to disseminated TB. And the result is that the urine LAM-LFA has been shown to reduce mortality when it is added to the diagnostic armamentarium in HIV-positive patients admitted to medical wards in Africa. In 2 trials, the absolute mortality reduction was 3% observed in 2 trials conducted in Southern African countries. Despite these advances, critical challenges in the diagnosis of HIV-TB remain, especially in patients admitted to hospital, where mortality remains high. These include difficulties in obtaining sputum samples for expert testing due to unproductive cough or confusion. Extrapulmonary TB is common in these patients, and these specimens are more challenging to obtain. And TB spread into the bloodstream is common in hospitalized patients with HIV, associated with higher mortality. Even short delays to TB treatment of a few days in these patients is associated with an increased mortality. Hence, radiology capacity and clinical expertise is required to facilitate timeless empiric TB treatment initiation for some patients, even when the novel diagnostics that I've discussed are available. A key global challenge is also limited scale-up of these new diagnostics, despite the fact that they are major breakthroughs. So for sputum expert testing, this was only used in the confirmation of microbiological TB in around 60% of patients in 2019. And in most high-burden HIV TB countries, this was in the 25 to 75% range. Access to the LAM-LFA is even more limited. In the 30 high-burden HIV TB countries, only 13 had a national policy and algorithm, and only 7 reported routine use. And this was not necessarily widespread use. It is concerning that this assay, which has been shown to reduce mortality in 2 trials, that's quite exceptional for a diagnostic assay, and costs only $3.50, has had such poor uptake. Based on the trial data, it should be used in the diagnostic workup of all HIV-positive patients admitted in medical wards in high-burden settings. Finally, regarding treatment, we have effective treatment for drug-susceptible TB, and treatment for drug-resistant TB with new drugs are evolving to be shorter, better tolerated, and achieving far better outcomes. Yet still around 1/3 of patients with TB worldwide remain untreated, and challenges with linkage, adherence, and retention undermine outcomes. To end, I've briefly summarized the evidence for approaches to TB prevention, diagnosis, and treatment, and highlighted implementation gaps. The scientific evidence suggests that wider and more equitable implementation of these tools will reduce HIV-TB deaths. In line with the DREAM presentation you heard earlier from Prof. Mfinanga, I also want to emphasize that these diagnostics prevention strategies and therapies will have maximum impact if introduced in health systems which are capacitated in terms of knowledge and skills and offering quality care, and thereby able to make the diagnosis of HIV-TB rapidly, deal with treatment complications that are frequent, and support adherence and retention. And I thank you for your attention.
So I think we've heard from all speakers on the importance of implementation strategies, quality improvements in healthcare delivery, and from Graham, the concern regarding lack of access to urinary LAM, which has been proven to reduce mortality in inpatients. So we're now moving to the Q&A session. I have a couple of questions so far for Nilesh. The first question is regarding the availability of 5FC. So Nilesh, the question is, can you go into some of the reasons why SAPRA have not registered 5FC yet?
Thanks for the question. So SAHPRA previously had registered flucytosine, but that was cancelled by the company about 10 years ago. And in order for SAHPRA to approve a particular medicine, register a medicine, a new dossier is required by a manufacturer to be submitted by a manufacturer. And this was done in December 2019. In recent correspondence with the regulator, they've specified that they need about 250 working days from the time that their technical screening is completed. So I think that more time is probably still required by SAHPRA to complete this.
Thank you very much. And also to you, what frequency were the adverse events among those on 5FC containing regimens?
So just to clarify, this was obviously an observational study. There was no standardized baseline testing or monitoring of laboratory adverse events. The vast majority of patients were on combination amphotericin B deoxycholate and flucytosine, and so the commonest adverse events related to amphotericin B, so predominantly anemia and renal dysfunction.
Thank you very much, Nilesh. There's a question on general CD4 and 5SC, but I'll just ask two more specific questions. The first to Prof. Mfinanga, what were the challenges in implementing the DREAM intervention and strategies?
Thank you, Angela. The most challenging were to reorganize a clinic into, I mentioned about the algorithm that we developed for diagnosis and treatment. So we had to reorganize the health facilities in order to fit in that algorithm and to be able to use bedside test, point of care test, which included rapid test for malaria, crack for cryptococcal, urine lamp, and then also, but we had to take to make sure that the investigation that we took for lab, the turnaround time is short. So we had to do a lot of training for lab people, for clinicians, and so on. This took a lot of time, but we also maintained it through the implementation so that the facility owned the process. It wasn't easy. That's why I say it was the challenge. But even though the CD4, as I said, the CD4 count testing was still a problem, but most significantly, the viral load, availability of viral load results, they are still a challenge that really need further intervention. Thank you. Back to you.
Thank you, Prof. Mfinanga. So Graham, I'd just like to ask you a couple more questions. The first is, what, in your view, are the key implementation strategies that already exist to reduce inpatient deaths from TB? You've touched upon them. And I'd like to pose to you the general question that has been asked by one of the audience. So the question is regarding availability of CD4 and viral loads. It says there's been great investment in HIV programs to increase access to CD4 and viral load testing. What is the missing link to ensure that testing is routinely done? Thanks, Graham.
Yeah, so in terms of hospitalized patients with HIV, TB, substantial mortality, studies showing around 20% mortality among those patients. I think the important thing is implementation that ensures a rapid diagnosis of those patients early after admission to hospital. In high burden settings where more than 10% of patients admitted with HIV have TB, I think the approach should be to have universal testing with sputum expert and urine lamb in those settings, or all people living with HIV being admitted to hospital, and making that accessible at the point of admission to hospital is a key implementation challenge. The issue is that the urine lamb will diagnose about 50% of patients. The sputum expert will obviously bring that to 80–90% of patients. However, many patients can't produce sputum for the reasons that I've discussed. And so that one still needs to have clinical expertise, radiology capacity, to be able to make an empiric diagnosis and start treatment rapidly in those patients where the clinical diagnosis is made. So, you know, in summary, it's access to expert and urine lamb, access to expertise in radiology, and ensuring that the turnaround time of the results is rapid, so that there's no delay. Even a delay of a few days can increase mortality. In terms of, you know, the issues around CD4 and viral load implementation and gaps, I think that varies by country. You know, there's issues around affordability in some countries, around lab capacity, and you know, certainly viral load testing is you know, an essential part of monitoring ARVs and picking up early ARV failure, being able to intervene and change therapy and prevent advanced HIV. The CD4 count no longer plays as important role in long-term monitoring, but is important in detecting advanced HIV and directing some of the interventions like, you know, cotrimoxazole preventive therapy and CRAG screening.
Thanks very much, Graham. So we've run out of time, but I hope we've convinced the audience and global health community on implementation, the lack of implementation as being a key driver of HIV-related deaths. We're now moving on to the next session.
So thank you very much to all our previous speakers. We'll now switch over to the next part of the session, where we'll have a brief overview of new developments and the research and development agenda for advanced HIV disease. And I would like to introduce our next speaker. So our next speaker is Dr. Isabella Ribeiro. Isabella is an infectious diseases physician with over 20 years of drug development experience, and she heads the dynamic portfolio unit within Drugs for Neglected Diseases Initiative, and is responsible for new areas of engagement for DNDi as an organization. And very specifically in relation to this particular session, she is the project leader for the Sustained Release through Cytosine project. Over to you, Isabella.
Hello, this is Isabella Ribeiro. I'll be presenting today an overview on R&D priorities, gaps, and recent developments in advanced HIV, as well as an update on the Sustained Release for Cytosine project implemented by DNDi and the 5FC HIV Crypto Consortium. As discussed earlier in this IAS satellite, there is this persistent and large burden of HIV-associated morbidity and mortality that has plateaued over recent years. As a key underlying cause, it relates to health system failures in antiretroviral rollout in resource-limited settings. As one concentrates on the key opportunistic infections causing advanced HIV mortality, one has a range of infections for which interventions that are known to be effective exist. There is thus this clear imperative to scale up the rollout of advanced HIV WHO recommended packages of care. At the same time, it's important to recognize the role of innovation. There is existing consensus on research priorities. WHO placed innovation as a major component of its strategies to achieve elimination of HIV as a public health problem by 2030. As we discuss innovation, we are talking in terms of research and development of new, improved diagnostic and treatment tools, but also critically in terms of improved diagnostic and treatment approaches and strategies, how best to deploy existing and future technologies, thus innovating in terms of clinical and implementation research. In terms of context of use, if one concentrates on inpatient care, there are a range of existing tools and strategies that have been shown to have a role in the management of advanced HIV. ACTA trial delivered on optimized strategies for cryptococcal meningitis treatment in resource-limited settings, early detection of TB in inpatients, urinary lamb for symptomatic cases have been already discussed in this meeting. On discharge, strategies in terms of tailored counseling, enhanced antiretroviral adherence, cotrimoxazole use, TB prevention strategies have an important role to play. As we look towards the future, We look forward to the results of the AMBITION trials to be released during this Congress, where the efficacy and safety of single high-dose liposomal amphotericin B therapy for cryptomeningitis is assessed. There is consensus on the need for research and development on new improved antifungals for cryptococcal meningitis and other fungal diseases of relevance for advanced HIV. Here we are discussing new chemical entities, but also new formulations of antifungals, including the example here discussed on the sustained release flucytosine that will be detailed a little bit further. We also need new tools for non-invasive diagnosis and management of pneumocystis pneumonia, CMV, and toxoplasmosis. Also, there is a need for assessment on burden and treatment of bacterial sepsis and histoplasmosis across the African continent. When we look in terms of implementation, we have the good news of the rollout of advanced HIV commodities in selected African countries, funded by UNITAID and implemented by CHAI. And looking towards the future in terms of implementation, the results of DREAM have recently been released as a model of advanced HIV care for CNS infections, and which really demands scale up and assessment. DREAM consists of a bundle of strategies, including health system strengthening, education programs, and communities of practice. A range of other implementation studies, additional health system strengthening, and access to strategic health supplies are also required and for assessment as we think forward in the future. In terms of outpatient care, we have discussed a number of the same interventions in terms of when in inpatient management. At the same time, here is worth highlighting the importance of preemptive treatment of cryptoantigen positive patients with fluconazole. As a key new strategy and evaluations to be carried out, includes the efficacy of new and existing strategies for the management of asymptomatic cryptoantigen positive, including optimal therapy and duration, the need for diagnostic and therapeutic lumbar puncture, safe drug and clinical monitoring schedule for the management of cryptoantigen positive patients. And here, worth noting the importance of the EFFECT trial, evaluating the 2 weeks fluconazole flucytosine versus fluconazole in asymptomatic cryptoantigen positives. We already discussed the relevance and importance of new medicines and diagnostics, and here the need for new antifungals that for inpatient also applies in terms of outpatient care, and also both in terms of new chemical entities, but also new formulations, with the example of flucytosine soon to be discussed. In addition, it's important to evaluate a range of existing new technologies such as omega CD4, Fujifilm, and others. Epidemiological studies in terms of bacterial sepsis and histoplasmosis are of relevance and importance also in terms of outpatient care. Zooming in to the sustained release flucytosine project, it aims at simplified inpatient-outpatient management of crypto infections, targeting a reduction in cryptomeningitis mortality. Flucytosine is the oldest antifungal currently in the market, and it's part of the first-line regimen for cryptomeningitis treatment. It is a treatment administered 4 times daily, and for which there are challenges in compliance in understaffed and overburdened hospitals in resource-limited settings. So beyond inpatient management, also it's important to highlight its relevance for early preemptive treatment strategies as one look towards reduction in mortality of cryptococcal meningitis. In discussions with partners, we have developed a target product profile, and we are currently working on pharmaceutical development of prototypes of the sustained release flucytosine for clinical trial evaluation. The dosage form selected is that of pellets for oral suspension, and to administration via orally or via nasogastric tubes. This 3-gram dose is to be administered twice a daily, will result in about 5 grams of pellets, which is about a tablespoon. The pellets would require mixing into a volume of water for oral or nasogastric administration. The key steps identified for clinical development and registrations consist of a phase 1 program with 2 studies. The first study in fast conditions in healthy volunteers, evaluating 3 prototypes of the sustained release formulation versus the immediate release formulation. And a second study, which has 2 parts, evaluating the selected sustained release prototype versus the immediate release formulation in fed conditions and steady state. The phase 2 program consists of a phase 2 open label trial evaluating pharmacokinetics and early fungicidal activity in patients with cryptomeningitis in Tanzania and Malawi. We're targeting WHO pre-qualification and registration in endemic countries. The initial countries of target for registration includes South Africa, Malawi, and Tanzania, where clinical trials will be implemented, but this will be expanded further in high-burden countries. The DTCP-funded consortium consists of this broad and strong partnership. We have different work packages with leadership of implementing partners such as PharmOvs as a phase 1 unit and partner in Bloemfontein, South Africa. The phase 2 study in Tanzania and Malawi with the leadership of NIMRI in Tanzania and the UNC Lilongwe Malawi project. The package on scaling up WHO guidelines and improved access for flucytosine has the leadership of St. George's, and the work package on data management statistics is led by the Luxembourg Institute of Health. As part of the access plans, we have a range of different activities, including engagement of the industrial partner on registration plans on the immediate release flucytosine and the future sustained release flucytosine. Also, advocacy efforts are planned in terms of increased availability of flucytosine-containing regimens in collaboration with partners such as the Cryptomeningitis Action Group, the CDC Foundation, MSF, and engagement with the UNIT-HI implementation project on advanced HIV. We're planning, and we actually are finalizing a demand forecasting assessment for flucytosine in different scenarios of use, and continue to discuss a potential integrated plan with the effect clinical investigators for potential assessment of the sustained release flucytosine. Also, recently initiated this assessment of opportunities for alternative quality liposomal photoresin B products, which is a product of relevance for a range of indications in advanced HIV. So we really hope that as one tackles access, that one would improve the maps of registration and availability of existing antifungals, including flucytosine in particular, but as one aims for ending crypto deaths by 2030. I take the opportunity to thank our donor, ADTCP, and our partners in this consortium, PharmOvs, NIMRI, UNC, Project Lilongwe Malawi, Luxembourg Institute of Health, and St. George's, as well as the DNDi colleagues that have been working in this project. Thank you very much.
So thank you very much, Isabella, for that excellent presentation and a quick overview of what's happening in the field of research and development. In your presentation, you did mention a number of advanced HIV disease-associated conditions and some of the research work that's going on. So I have a couple of questions for you, Isabella, perhaps to elaborate further. And my first question is borrowing from some of the earlier presentations and also just listening to the kind of implementation challenges. Could you highlight from your view why we seem to have, I would say, slow progress in research and development of perhaps new agents or more user-friendly agents towards some of the advanced HIV-related conditions? We don't hear much about histoplasmosis in terms of the development work and a number of other conditions that Ajay referred to. So could you elaborate what you see as the gap or what perhaps could be done to accelerate research and development towards these areas?
Thank you very much, Irene, for the question, and it's a very important one. I think the challenges with innovation and research and development of new tools for advanced HIV actually are the same and in line with a number of the challenges that we see with research and development for neglected patients more broadly. I think that there are elements to it that relate to the investments, to the need, and to actually a framework of research and development that is driven by needs. And here, I think though that we have been seeing some changes and initiatives and that are acting to move and advance and make progress in this area. I think that particularly when we look at antifungals, certainly the portfolio and pipeline has evolved over recent years. I think we have, through some of the presentation from Graham, some of the earlier talks, also both in terms of the investments that have been done, both in terms of new tools and implementation approaches, things, particularly the investments, for example, the examples that were given from EDTCP, I think that highlight some evolution, but this when you talk about research and development, it's actually something that needs to be sustained, right? It's actually not something that you can do and only and stop and start, but really sustain over time, and to do so, it's actually it has not been consistent over the years. So a difficult question to answer appropriately, and some evolution, some advances for sure, but much more to be done.
Yeah, thank you, Isabella. I think part of the presentations, obviously, that have come before you have highlighted some of the key issues in regards. Part of it perhaps is the need to generate more data and a lot more advocacy towards that. So maybe just finally, we have heard previously of combined preventive therapy for some of these AHD-related conditions, but there hasn't been much talk towards it. I don't know if you have any word to say about that.
I think this is it's a very important point indeed, Irene. I think that when we discuss combinations, it's among strategies that have and actually integrate assessment of an integrated package of interventions. So I think this is indeed something that we need and should be highlighting as one moves forward. Thank you.
Thank you, Isabella. So because of time, we'll end that session there. And at this point, please keep posting your questions. We will have an opportunity after the IAS conference to respond to any questions. So please feel free to continue posting your questions in the Q&A session. And I'd like now to hand over to Amanda Banda to take over now for the panel discussion. Thank you.
Thank you so much, Irene, and to the great panelists. So I think that I would like to take us through the last 20 minutes of this session. And in this session, we have a high-level panel to brainstorm on what exactly is needed to end this four-decade-old pandemic and address some of the issues and challenges that have been highlighted in this session. So with me, joining me in this panel is Dr. Zukiswa Pilini. She is the Chief Director of the NDOH, HIV, AIDS, and STI Department of Health in South Africa. And also joining me is Dr. Shannon Heder, who's the Deputy Executive Director and Programs at UNAIDS and also Assistant Secretary General of the United Nations. And joining me as well is Dr. Ajay Rangaraj, who's the Technical Officer at the Department of HIV at WHO. And also Dr. Batrin Kilingo, who's a palliative care practitioner and the Treatment and Knowledge and Research Lead at ITPC. And lastly, Dr. Gilles Van Kutzen, who's the AIDS Working Group Team Leader at NSF. So I have very specific question for these panelists that I would like them to respond. And because we are running out of time, of course, I will ask you to be very brief. So my first question goes to Dr. Pilini in South Africa. And I think that amongst the audience, I guess this is maybe a similar question that audience might be thinking and maybe also wanting to ask similar people in your position in their respective countries. So we just wanted to find out what is South Africa's plan to accelerate access, and I think specifically to registration of flu Cytosine, but also the tender for liposomal amphotericin B in South Africa, but also the scale up for TB-LAM. Thank you.
Thank you for the question. Good morning. We start with the scale up of TB-LAM in South Africa. Just to give a background that South Africa is re-implementing the TB-LAM across all provinces. Provincial TB-LAM training is underway, focusing mainly on primary healthcare facilities to increase commodity coverage and uptake, as the commodity is now going on tender. So TB-LAM was first introduced in South Africa in 2017 to facilitate TB diagnosis in advanced HIV disease patients. Most of them were admitted in hospital, so it started in hospital because they were very ill. During that period, national demand and procurement was restricted to select provincial hospitals. However, the strategic re-implementation project was introduced to focus on optimized procurement through the following interventions. We had revision and disseminated national TB-LAM guidelines, development of training materials, including posters and admin algorithms, new TB identification register to accommodate TB-LAM test for data and recording, and the point of care monitoring and evaluation SOPs to aid clinicians with management of data processes. So there's a rollout to facilities, there's a rollout training to facilities regarding TB-LAM, and that has increased in uptake. In 2020, the TB-LAM pack size was changed from 100 unit pack to 25 unit pack to help address access barriers in the provinces. Now that is available, and the provinces have started to order TB-LAM kits that are in 25 in boxes for implementation at primary healthcare services. So you also asked about the tendering of the amphotericin B in South Africa. We hope that the ambition cryptococcal meningitis trial will show that the regimen of single high dose liposomal amphotericin B followed by 2 weeks flu Cytosine is non-inferior to the current WHO standard, which is a 1 week amphotericin B deoxycholate and 5-FC. This new regimen could greatly simplify treatment of people with cryptococcal meningitis and reduce the time in hospital. While the liposomal amphotericin B is currently registered in South Africa, the current cost per 50 milligram vial is approximately 100-fold greater than that of a vial of conventional amphotericin B. So the National Essential Medicines List Committee would need to examine the overall cost effectiveness of this regimen compared to the current standards of regimen. You also asked which one, or you also asked about Cytosine and
registration of
availability.
Cytosine.
Registration. I think Professor Niles responded to that to say that there was a 500 milligram formulation that was registered, which was cancelled by the company. And now the company has to send another dossier, and it takes some time to look at that. But currently we have received the application of a 250 milligram formulation that has been submitted for your registration, and it is currently under evaluation. So we'll hear from SAPRA after the period of evaluation has elapsed. Thank you.
Thank you so much, Dr. Pinini. My next question, I think we will come back to some of those conversations at the end of the session, but I would like to move to Dr. Shannon Hader at UNAIDS. So we all know that UNAIDS is mandated to mobilize and bring together various stakeholders around key issues in the HIV response. And so my question to Dr. Hader is, are there any ambitious advocacy plans by UNAIDS to ensure that donors at the global level and governments and strategic players actually do prioritize the major killers, especially cryptococcal meningitis? And so what exactly needs to be done to mobilize and get everybody around the table to discuss this very critical issue and take it to the next level? Thanks.
Thanks, Amanda. And I just want to start actually by recognizing, I think when Ajay put up his first set of slides, the reality trial, whose principal investigator was Dr. James Hakim, was one of the stalwarts for expanded prophylaxis. And I just wanted to recognize that he passed away this year, just a few months ago from COVID. This is over a year into COVID when we know how to treat it. And this was after in so many countries, healthcare professionals had already been vaccinated. So I think he's such a giant in our field and such a personal mentor. I just wanted to recognize him in this session, which he would care a lot about. So I love your question, because I think, the premise of this session has been implementation failures. And from UNAIDS, I always have to ask them, so what's the political failure? What's getting in the way of this? And it's true that the Global AIDS Strategy and Political Declaration that just came out doesn't highlight advanced disease, really. And so what's going on there? Because I think that says, what do we have to do to make it better? And it's not going to be very popular for me to say that, but I have to disclose, over the last couple of years of the strategy process, I have to tell you, it was really hard to even keep mortality, the idea that people are still dying of AIDS, on the table in a lot of rooms for discussion. We missed as a globe the mortality targets for 2020 by 50%. We were 50% above where we wanted to be. And we were 300% above where we wanted to be for prevention or new infections. And somehow I think with the very important focus and refocus on prevention, I feel like we started to slip a little bit backwards in that old-fashioned prevention versus treatment battle that made folks just not even want to talk about mortality as much. I do think that COVID actually changed that a bit, because I think people saw so much mortality again in a broader setting that somehow this became a more tangible factor again. But it shouldn't have taken that, right? We still have nearly 700,000 deaths per year from AIDS. We still have the rate of improvement of mortality is declining. We're getting slower and slower in our gains, and we still have massive inequalities. Kids make up 4% of people living with HIV and 14% of deaths. So this is clearly a huge problem. So what can we do about it now? How's the way to, and what are the next opportunities to get really specific on this? And I think one of the best opportunities coming up is WHO is embarking on its global health sector strategy for 2022 to 2026. And of course, WHO is part of the UNAIDS joint program and really the health sector specialist. And in addition to the specifics covered today on opportunistic infections, I think in our earlier session, earlier this week, you know, Sharon made a very big point about, and tertiary care and hospital care seems to have just fallen out of vogue. And certainly this is both a systems issue and an HIV and other things issue. And I think this global health sector strategy, where yes, there's going to be an HIV and TB and, you know, STI and hepatitis segment, but also bringing across diseases together, I think it's a time to say, like, how do we keep this sectoral strategy from repeating what we have experienced over the years in prevention versus treatment? How do we keep this from becoming, let's say, a primary healthcare versus a tertiary healthcare versus a continuum, so that we can really also address what are the investments that provide that platform for the specifics we covered here today. You know, I have my own personal non-UN little assessment I do of political will for this kind of advanced care. And I sort of think, wow, if a country's political leaders leave the country when they're sick to get care elsewhere, what does that say about the attention and the willingness to invest in people and the willingness to show we need a spectrum of care, from prevention, from early diagnosis, all the way to advanced disease, if we're going to make progress overall in people's lives? And if we're also going to continue to reduce fear and reduce stigma about a disease by, you know, reducing some sort of a futility factor that you're going to get sick and die if you're finally diagnosed. So I think we've got a lot of work to do together. I think that this is not the year to slow down on this, but particularly as we are still in the middle of COVID and coming out of COVID, this is a time to really focus in on this part of the care spectrum that hasn't achieved everything we know is possible to achieve.
Thank you so much, Dr. Hayder. And I think that really transitions well to my next question to WHO, of course, which we know you've also highlighted, and I think it's been highlighted earlier, the plans for WHO for the release, and they're currently in consultations at the moment on the strategy on HIV, hepatitis, and STIs. And as you've mentioned, that's one of the next great opportunity. But in addition to this and outside of this, I think my next question to AJ at WHO is, we know that also recently major health organizations have released an advocacy framework actually calling for an end crypto meningitis death by 2020 strategy. And so I wonder, is this something that WHO will consider outside and in addition to the strategy that Dr. Hayder has spoken about?
Thanks so much for I think it's a really important question. So WHO strongly endorses the global strategy to end AIDS-related deaths by 2030. And I think it's also important to acknowledge that this absolutely includes cryptococcal disease and other opportunistic infections, because we have a spectrum of diseases that are causing tremendous mortality in this group, and that includes cryptococcal disease, but we also have tuberculosis, we also have severe bacterial infections, and I think these are all things that have to be targeted. And of course, we still support the public health approach, meaning which it has to benefit all people living with HIV who have advanced HIV disease here, at least, you know, speaking specific to advanced HIV disease. WHO will continue to provide the necessary normative and technical guidance that is required by countries. And currently, our focus is to ensure that countries are able to implement the advanced HIV disease package as it stands and build back better during this COVID-19 crisis. I think that's sort of an emergency focus at this stage, but that does not mean that, you know, we leave behind plans for the future. Further, we'll also, as I mentioned in my presentation, we are convening an expert consultation for severe bacterial infections, which of course is one of the 3 top causes of mortality in individuals with advanced HIV disease. And we're really looking at a path forward in terms of normative guidance. We also plan to host regional consultations to identify region-specific issues relating to implementing the advanced HIV disease package. and what adaptations are needed to ensure that it's successfully rolled out. And I think it's important that this key bridging piece of work happens, because I think we have a broad set of tools that can be used to manage advanced HIV disease, but I think we need to be able to work with countries to translate that into active programs and policies. So also, again, I would like to reiterate, WHO also continues to support the ongoing projects, such as I mentioned earlier, the UNITAID Clinton Health Access Project for liposomal amphotericin is one such example. And I think this can serve as a potential model to implement in other countries as well in the future. And and I think also it's also worth saying that there are a number of interventions that have overlapping use and utility. So such as one such intervention is, of course, the CD4. So it's important to also recognize that dichotomy as well. It's we have to look at the CD4 as a tool that will serve as a tool to guide and trigger vital interventions in people with advanced HIV disease. And as well, the viral load is intended to monitor routine care and identify a need for changing ART regimens where applicable. So I think that dichotomy is also important to understand. And needless to say, we will continue working with countries to ensure that there is adequate cover for advanced HIV disease. And again, of course, when it comes to interventions, so we are sort of eagerly awaiting the results of the Ambition trial, and of course WHO is actively assessing the various pieces of information needed in order to convene a guideline development group and subsequently guidelines. But more to come. Okay. Thanks very much.
I will have to cut you short. Thank you so much, Dr. Ajay. And so my next two questions, I would like to ask the respondents to be very brief because we're running out of time. And so quick question to Batrin is, I know I'm from civil society, and so we've heard, I think, from Ajay, from Shannon and others, and the panelists, and sometimes we feel like things are not moving fast enough. And so there is recognition that people are dying and these are preventable deaths. So what is the role of civil society in advocacy towards this? Because this is a topic that's not yet high up also in the civil society advocacy agenda. So what will it take? And also my question to Gilles at MSF is, MSF is implementing programs. And I think having heard from the panelists in this session, what do you think is still missing in terms of responsiveness and rapid move to end these crypto deaths by 2030? So over to you, Batrin, and immediately after that, to Gilles. Thank you.
So thank you very much, Amanda. So we are very likely to go in reverse and go back to the 90s, where we had so many preventable occurrences of deaths as a result of advanced HIV disease. And I think it's extremely important to recognize that central to making any progress, any achievements, we must involve communities of people living HIV and civil society in the following ways. That first and foremost, treatment education is important. People living HIV need to be made aware of the importance of the use of antiretrovirals, the use of monitoring treatment success, but also the real truths around the occurrence of various opportunistic infections. People getting to understand and know that screening is extremely important. The early diagnosis of various opportunistic infections, and then of course making sure that the various preventive aspects of these opportunistic infections need to happen. Once people have been provided, this education and provided pieces of information, then they are able to advocate and demand for various services that we have talked about in the last hour and a half. And lastly, to also make sure that communities and civil society are involved in policy making, in implementation of some of these programs, including task sharing and monitoring the successes of these programs that we've talked about. So that really is, in a nutshell, what entails any success of any of this stuff that we've been talking about. Thank you.
Great. And so, Gilles, I think over to you.
Yes, thank you, Amanda. Shannon has addressed many of the things I wanted to say, especially in terms of lack of policy. But first of all, while CD4 TB screening with TB LAM, screening for cryptococcal antigen with CRAG, LFA have been introduced in many national protocols, implementation remains very low and is unequal between countries, with some countries having slightly better and others having virtually no implementation. That's what we see in the field with MSF. So, you know, I think we really need to focus on scaling up the package of care of advanced HIV to hospitals, but also to primary care, because in the end, early identification of opportunistic infections and timely initiation of treatment or preventive treatment is the key to decreasing mortality. And then we should focus on countries with the poorest coverage. In terms of strategy, we have the 95, 95, 95 strategies, the UNAIDS strategies, the NTB strategy, but there is no strategy addressing major causes of death, such as cryptococcal meningitis and severe bacterial infections. The UNAIDS strategy and the recent political declaration on HIV do not refer to advanced HIV disease and do not spell out on how to reduce mortality. They mention a very good target of 250,000 deaths by 2025, but they do not tell us how to get there. So I think it's critical that the WHO global strategy on HIV, hepatitis, and STIs does include clear targets and a roadmap towards addressing HIV mortality and the main causes of death. There's another opportunity is, as we speak, the Global Fund is developing their strategy. I think there as well, it's important the Global Fund strategy spells out clear targets and implementation plans for advanced HIV and how to reduce mortality. And in parallel, there is a need for the major funding agencies such as PEPFAR and the Global Fund to fund commodities for advanced HIV, including diagnostics and drugs for opportunistic infections, and to ensure that these are provided free of charge. In most of West and Central Africa, antiretroviral therapy is free, but treatment for opportunistic infections, with the exception of TB, is paying. And so people die because they cannot access treatment for major opportunistic infections. And then we've spoken about cryptococcal meningitis, which remains severely neglected and needs its own strategies, but probably even more neglected are severe bacterial infections. And I would ask to have a particular attention to Salmonella non-typhi bacteria, which is the major cause of sepsis in people living with HIV. In our Kinshasa program, we find that more than 85% of these are resistant to ceftriaxone, the first line antibiotic treatment. So I would ask for enhanced attention towards surveillance of causes of severe bacterial infections and of antibiotic resistance amongst those, because I think that's going to be our next challenge in the years to come. Yes, and yeah, that's it. Thank you.
Okay. Thanks a lot, Gilles. So for me, I think the key takeaway from this session, I think that's something that's highly come out, I think as a recommendation, but also as a next step. I think it's the missing how. Yes, I think the UN high-level political declaration does target 250,000 deaths, but it's missing the how to get there. And I think we are all sensing that we do agree that this strategy to end crypto deaths will be critical. And there is the opportunity with the upcoming global strategy from WHO on HIV, STIs, and hepatitis to really put a special emphasis on this. And so I think that from Dr. Panini, and I guess this is very similar to other implementing governments, the issues and barriers around registration, but also the slow implementation and scale up of access to tools, diagnostics, and medicines is a big challenge, with also the pricing and the cost being a major barrier. And I think from Dr. Hader, we did hear that, yes, it's also a matter of political failure in terms of focusing and prioritizing this issue. And the opportunities do exist. And I think it's up to the people in this room, in this panel, to move the discussions forward and really put the focus where it should be. I think from AJ highlighted the opportunities around strategies that exist, but also the work that WHO has lined up in countries at the global level in terms of support, but also the potential consultations at regional levels, on crypto. And I think from Battery, the key point is involve civil society, and treatment literacy and education is going to be key. And so thanks to Gilles for also a very good wrap-up summarizing all the key issues and highlighting the importance of scaling up the package of care at primary and tertiary levels, but also surveillance. And so I will hand over back the session to Dr. Irene and Dr. Ford. Thank you so much.
Thank you very much. So I will hand to Irene shortly. I was asked to give a summary of the highlights of this session, and really there are too many to do in the little time we have. So I would simply like to highlight the fact that we have this session at all. I think what is featured at the IAS conferences is a symbol of what is important in the AIDS response. And if we went back 5 years ago to an AIDS conference, we would see much less attention on advanced HIV disease to what we see today. So I think we can take the fact that we have a number of sessions on advanced HIV disease in this conference as a sign that advanced HIV disease has moved higher up the agenda, and that's fantastic news. So I would just like to end there with that positive note and hand over to Irene for next steps. Thank you.
Thank you, Nathan. I think, as you've rightly said, it's almost impossible to summarize everything that's been discussed. I think for me, overall, it's a sense of urgency, which I think in a way, gives us some element of anxiety, but also positivity. In a number of presentations, it was very obvious that we do have the tools. And perhaps what we are missing is the how, as Amanda has very rightly summarized from the panel discussion that's come out. I think also maybe just to highlight from the R&D component, and I don't want to repeat a question that came in, but it was, sort of to say that if you look at what's happening in the field of antiretroviral therapy, we are discussing about long-acting agents, alternative delivery methods. And it seems that we haven't yet gotten to that conversation in relation to advanced HIV disease and related conditions. So perhaps some catch up to do. But again, as I said, lots of interesting discussions. I do want to highlight some of the key things, I think, in terms of the next steps. Definitely, as AJ highlighted, there are a number of next steps and convenings that WHO has talked about, and Shannon has also highlighted the direction that we see UNAIDS moving into. From our part, as the co-organizers, definitely we do look forward to plugging into a number of these discussions and hopefully being able to reconvene all the excellent speakers and the panelists in this session to continue this discussion. I think the time is right. It was probably yesterday, but today is the correct time for us to move forward. And we do look forward to engaging you and reaching out to everybody. I do want to take this opportunity to thank everybody. First and foremost, thank you very much, Nathan, for co-chairing this session with me. Also to thank the organizers. There were a number of people behind the scenes of this session. So WHO, DNDi, colleagues from St. George's University. And also really to give my vote of thanks to the excellent speakers, panelists, co-moderators, and everybody who's made this session a success, and the very able technical support from the IAS team. Thank you, everybody. We wish you well for the rest of the conference, and definitely looking forward to engaging more. Thank you.